Hello everyone, my name is Haley and today my group will be presenting on a case study of a patient with an ankle sprain. I will be presenting alongside my classmates Aaron, Kendall, and Lucas. Our patient case, as mentioned before, is on a patient with a possible left ankle sprain. Our patient is a 32-year-old female high school math teacher who had an active gym routine that included Zumba and yoga classes. She sustained a forceful left ankle inversion while playing volleyball 3 months ago. Due to the timeline of this injury, our patient is labeled as having a chronic condition. Aggravating factors for her ankle pain include a 6 out of 10 pain while twisting her left foot, 5 to 6 out of 10 pain while doing Zumba. These moves include twisting on the planted left foot, and 4 out of 10 pain with stiffness while squatting. Stopping her Zumba routine, sitting with her legs propped up on a couch, and acute icing helped ease her patient's pain. The 24-hour model of our patient's symptoms include morning left ankle stiffness and evening ankle stiffness, and up to a 1 or 2 out of 10 pain, depending on daily activity. She noted no sleep difficulty. Our patient's goals include returning to her Zumba routine, to be able to walk downstairs without stiffness, and to squat without symptoms. We have looked at 5 possible outcome measures that we would use for our patient. The first outcome measure we looked at was the STAR Excursion Balance Test, called the SEBT. The SEBT is used to screen deficits in musculoskeletal control, such as ankle instability. The assessor then compares the results of the test to the patient's uninjured leg. We also looked at the single limb hop tests. These are a series of hop tests such as the single limb hop for distance, the triple hop for distance, and the 6-meter timed hop. These single limb hop tests are used to assess lower extremity function, are typically used to assess function and return to sport. We also looked at the lower extremity functional scale called the LEFS. The intended population of the LEFS are adults with lower extremity conditions that include a wide array of lower quarter symptoms. The LEFS is a self-report questionnaire. Next, we looked at the foot and ankle ability measure called the FAAM. We ultimately choose the FAAM as our outcome measure. The intended population of the FAAM are patients with foot and ankle related impairments. The FAAM has 2 subscales, the first being an ADL subscale with 21 items and a sports subscale with 8 items. We also noted that it was important to include the Foot and Ankle Disability Index, called the FADI. The FADI addresses functional limitations related to foot and ankle conditions. We looked at the FADI because it is a former version of the FAAM. The 2 are similar except for an additional 5 items on the FADI that address pain and ability to sleep. Ultimately, these 5 questions were removed from the FAAM to improve psychometrics. I will now let Kendall speak about why we chose the foot and ankle ability measure as our outcome measure.
All right, now that Haley has talked about our patient case and gone over all of the outcome measures we looked at, I will be talking about why we ultimately chose to go with the foot and ankle ability measure. So when looking at the lower extremity functional scale, although this is a great outcome measure for looking at the lower extremity in general, it's not very specific for ankle pathologies. So we thought either the foot and ankle ability measure or the foot and ankle disability index would be more appropriate for our patient. Another important thing to note is that the lower extremity functional scale does not include a sport-specific subscale, which we believe is important for our patient since she is a very active person. The performance measures that we looked at included the STAR Excursion Balance Test and some single limb hop tests. And although these measurements can give us some important objective measures of a patient's ankle stability, they don't really give us any information about the patient's day-to-day functioning with their activities of daily living. So although it might be appropriate for this patient for us to do a STAR Excursion Balance test with her in the clinic, if we're only able to choose one outcome measure, we thought it was most appropriate to choose a patient-reported outcome measure because this is going to give us a more complete picture of the patient. Also, we decided that the single limb hop test may not be appropriate for this patient. The single limb hop tests are more for athletes who are returning to sport after sustaining an injury. And although our patient is very active, a single limb hop test may not be appropriate and may actually be too rigorous, especially if she's never been educated on how to properly perform a single limb jump with correct form. So that left us with the foot and ankle ability measure and the foot and ankle disability index. And ultimately, we decided to go with the foot and ankle ability measure. And this is because, like Haley mentioned, the foot and ankle ability measure has improved psychometrics over the foot and ankle disability index. The foot and ankle ability measure is a little bit more succinct. It has 5 fewer questions than the foot and ankle disability index. And today, clinicians actually prefer to use the foot and ankle ability measure over the foot and ankle disability index. Another thing that is important to note is that the foot and ankle ability measure has a minimum clinically important difference as well as a minimal detectable change, whereas the FAAM only has an MDC. So we can use the FAAM to know when a patient is truly improving in their ability after treatment, a little bit better than if we were to use the foot and ankle disability index. So that is ultimately why we chose to go with the foot and ankle ability measure for our patient. Now, Erin is going to describe the foot and ankle ability measure and how it can be used to measure ankle stability.
So before we learn how to apply it, let's talk about what FAAM actually is. Essentially, it's just a questionnaire. It assesses the physical function for individuals with musculoskeletal disorders in the leg, foot, and ankle based on patient-reported outcomes. But it includes 2 separate subscales. The first is a 21-item subscale that measures functional limitations during ADLs. The second is an 8-item subscale that measures the restrictions in sport participation compared to prior level of function. And of course, we can see here that this outcome measure focuses mostly on activity limitations and participation restrictions according to the ICF model. So how do we score a FAAM assessment? Well, the questions asked in each subscale set can only be answered in one of 5 different ways: either no difficulty, slight difficulty, moderate difficulty, extreme difficulty, or unable to do. Each of these responses are then equated to a numerical value from 0 to 4, 4 being the least difficult and 0 being the most difficult. Upon completion of the FAAM, you'll add up the scores, divide by the total possible points in each subscale, and multiply it by 100. It's important to note that you should end up with 2 scores, one for the ADL subscale and one for the sports subscale. You will not be combining these scores since they are addressing different levels of the ICF model. The ADL subscale has 84 points possible, while the sports subscale has 32 points possible. After dividing your raw score by these values respective to their subscale set, you should end up with 2 percentage values from 0% to 100%. And it should be somewhat obvious here that the higher the score reflects a higher level of physical function. And another way we can interpret this percentage score is through juxtaposition against a patient-reported percentage of their prior level of function. That will require patient blinding to their subscale percentage scores and then asking the patient, how would you rate your level of function on a scale from 0 to 100%? 0% being the complete inability to function, and 100% being your prior level of function. You'll ask this question twice, one with regard to ADL function and the other with regard to sport function. Although this outcome measure is subjective in nature, it allows us to quantify and score components of daily activity or sport and then compare it to the holistic perspective of each patient uniquely. Now, some things to consider before using this outcome measure are: is a component of activity limited by something other than the patient's foot or ankle? If the answer is yes, then have the patient write NA or not applicable for that particular subset item. However, for this outcome measure to be valid, it does require that the patient is able to answer at least 20 out of the 21 items in the ADL subset and at least 7 out of the 8 items in the sports subset. If the patient's unable to answer 2 or more of the items in either subset, then the outcome measure is now invalid. That said, studies have generalized the use of this outcome measure for patients in outpatient ortho for musculoskeletal disorders of the lower quarter over a 4-week time period. Further studies are needed regarding the validity of the FAAM score in other settings or over a different time frame. Also, emerging studies should investigate the reliability and responsiveness for this outcome measure across different functional levels. And now Lucas is going to walk us through more of the psychometrics for FAAM.
Okay, so now we're going to talk about some of the numbers that Kendall alluded to earlier. To do this, we looked at an article from 2005 titled Evidence of Validity for the Foot and Ankle Ability Measure. This paper included multiple analyses for reliability, validity, and responsiveness, and was designed to provide evidence for interpretation of scores for both the activities of daily living subscale and the sports subscale. The study included 243 subjects. 164 of them were expected to change, and 79 of them were expected to remain stable. The subjects were given the foot ankle ability measure and the comparison measure on 2 different occasions, 4 weeks apart. The comparison measure was the SF36. Based on a power analysis, approximately 220 subjects were required to detect significant values in responsiveness metrics. So this study does meet that criteria. It's important to remember, like Aaron said, that the point scores in the responsiveness values are percentages out of 100 and not the raw scores. What they found is for the ADL subscale, the minimal detectable change is 5.7 points, and for the sports subscale, the MDC is 12.3 points. Onto MCID, the minimal clinically important change for the ADL subscale is 8 points, and the MCID for the sports subscale is 9 points. When looking at reliability, the intra-class correlation coefficient is 0.89 for the ADL subscale and 0.87 for the sports subscale. Both of these have good reliability due to the ICC being in that 0.75 to 0.9 range. And last, we have validity. The correlation coefficient of the ADL subscale is 0.84, which is considered excellent, and the correlation coefficient of the sports subscale is 0.78, which is considered adequate. And here is our references, and thank you all for watching.